will be underway. And we are live. And Dr. Jon Hewitt from Cardiff, welcome. You are a specialist lead for stroke and a lecturer in geriatric and stroke management, I believe, at Cardiff University. So nobody on this earth probably knows more about stroke than you do at this particular moment.
I don't know about that. I can probably hold my own, but I think there are possibly some more knowledgeable people around. But yeah, anyway, I'm glad to be here. Thank you very much for asking me to come and talk to you.
My pleasure. Now, we often think of stroke as being something that, happens to old men mostly, not really women. We don't seem to think about it much about women. And we also think about heart attacks affecting men more than women. But stroke and heart attack are actually, depending on which country you're in the top 3 or 4 killers of women. So do you think that women take this seriously enough?
Yeah, I think they do. I mean, I would agree that it is very much a disease of age. We do see strokes in men and women younger. But typically, strokes increase from the age of about 60. We see it in both sexes. I think, and it affects men and women. So I do think they take it seriously, because a lot of the stuff that we'll talk about later about how to prevent a stroke is sort of basic kind of public health medicine, which I think most women certainly a lot of women do engage with.
Yeah, it's interesting. I did one on dementia risks the other day, a chat with a doctor friend of mine, Dr. Ginny Mansberg, who's just written a book, Save Your Brain. And I didn't realise that if you've had a stroke, there's a 60% your risk of dementia is 60% higher.
Well, yeah. So stroke is a disease of the brain, and we'll come to that. And it affects the blood vessels. And if you have lots of little strokes, in effect, it's just damaging the brain globally, which is essentially what a dementia is. And actually, having a bit of a sidetrack, dementia in the sort of broader sense means an impairment of thinking. And we often think of Alzheimer's as being dementia. And actually, Alzheimer's is about half of all the cases of dementia, but about a third of the causes of dementia is what we call cerebrovascular disease. So that is actually little strokes of the brain. And then you've got the sort of rarer causes. So actually about, the second biggest cause of Alzheimer's disease, of dementia disease, 50% is Alzheimer's, the other 30% is stroke disease. Actually, that's coming down a bit, which is quite good, because things, again, which we are going to talk about, like cholesterol, putting usually on a very sort of on a blood thinner to stop you having strokes, controlling blood pressure, as well as stopping the bigger strokes that we think of. It's also stopping these little strokes as well. So one of the sort of good news stories in dementia as well, and I know there was actually some positive news about Alzheimer's yesterday, actually, but is the fact that actually we're stopping those little strokes a little bit more. So that part of dementia is not getting bigger, if you know what I mean. So there's a bit of a handle on that. So that is a bit of good news. Anyway, sorry, we're going on. That was cerebrovascular disease, which
we will get to that. Yeah. Shall we go back to the very, very beginning then? Because there are different types of strokes that people may not necessarily be aware of. So what is a stroke, and what are the different types?
Well, what I would say to my patients is a stroke is an interruption to the blood supply to the brain. And where you have an interruption to the blood supply to the brain tissue beyond where the blood comes, it's just like plumbing. If you block a pipe at the bottom, there's more affected at the top. If you block a pipe at the top, there's a little bit less affected. But beyond, downstream, if you like, that is where damage can occur to the brain, and that's where you get the strokes. In the UK, 4 out of 5 strokes are where you have a blockage, and about 1 in 5 strokes is where you have a bleed, so the blood vessel bursts. Those figures change very slightly, particularly in China. Southeast Asian populations have a higher risk of bleeds. Actually, it's about up to 50-50 actually in some populations, but generally in sort of Western populations, it's 4 to 1.
Okay, and do we know why those sorts of differences between ethnic groups exist?
Yes, not absolutely definitively, but there's possibly a genetic risk in certain populations, and there's probably a bit more hypertension, high blood pressure, certainly untreated high blood pressure in Chinese populations. I think that's probably what is driving that, because the high blood pressure is a risk for all types of stroke, but particularly a bleeding type of stroke.
Okie dokie. We will spend a lot of time on high blood pressure as we go through this. The other thing as well that is the heart attacks. What's the relationship between strokes and heart attacks? Are you at more risk one or the other, or are they related as a cardiovascular disease? How do they come together?
Yeah, I mean, they're very close cousins, to be fair. I mean, most heart attacks, as you imagine it, where in fact, instead of a blockage to the blood supply to the heart, you've got a blockage to the blood supply to the brain, you've got a blockage to the blood supply to the heart. So essentially the blood vessels that feed the heart, that give it the energy to pump, have their blood supply interrupted, and that can cause the heart muscle to die, or it can cause the heart to beat irregularly. You don't get many bleeds into those blood vessels. That would be quite unusual, but it tends to be a blockage. And basically, they're caused by the same thing. They're caused by high blood pressure, high cholesterol, poorly controlled diabetes, etc. So the risk factors are exactly the same. So they are diseases of blood vessels. So they are very, very closely related. Same as you've got, if you have poor blood vessels in your legs, it's a similar process. If you have sort of poor circulation, so it's a disease to the arterioles, and arterioles are the bits that take the blood, so the bits with oxygen in. It's a disease to those blood vessels. Diseases to the veins are a little bit more unusual. Certainly, you can get some unusual types of stroke with the sort of if you have a blockage in the vein, so the blood isn't draining from the brain. Interestingly, with the COVID vaccine, that was the type of stroke that was associated with that. It's called venous sinus thrombosis. We have a weekly meeting in Wales, and we didn't see an increase. I probably see one person a year with this normally. I mean, perhaps over the whole population, I think there was a very slight increase in that. But we also know that actually more people probably had a stroke from having COVID, because it thickens your blood. Any infection thickens your blood. Anyone who has any infection, statistically, a little bit further down the line is likely to have a stroke or a heart attack anyway. So more people had an infection with the COVID and actually had a stroke than actually had a problem with the vaccine. I'm not saying it wasn't there. It was there, but it really wasn't something we saw. But that was the type of stroke. It's where you have a blockage to the drainage, the blood draining out of the brain, and that causes back pressure because the blood isn't draining away. Sorry, got a bit technical there.
No, that's all right. What we find with women generally is that before menopause, their heart attack and stroke risk is lower. Then they seem to catch up with men post-menopause around about the age of 65. Do we know why?
I think we've got a very good idea. Estrogen does seem to be protective for blood vessels. So when up to the point of menopause, women have high estrogen levels, and obviously those drop at the menopause, and the risk sort of comes down to about the same sort of level as men, more or less, perhaps slightly lower. But it's probably the estrogen before menopause.
And so do we know, this is the 64 million pound question, I guess, that there seem to be, as with dementia, we have conflicting studies as to whether or not HRT is protective or not protective. What's going on? Do we know why we have conflicting studies? Is it because of the types of HRT that were looked at? I know menopause is not your area specifically, but what are your thoughts?
Well, I mean, I think, in the broadest sense, HRT isn't an exact science, in the sense that different women get different preparations at different times. So it makes comparing exactly the same thing quite challenging. I think that there is probably evidence suggesting that HRT may increase the risk of a stroke. Not massively, but a little bit, and possibly in the first sort of year after taking it, the risks may be a little bit higher. The evidence is, it's not completely definitively one way or the other, but there was a very big paper came out last year from the UK Biobank, which is a very big UK study. It's got 500,000 people in it, so 250,000, because half of them were women, so we're not looking at the men. But the women that started HRT had a higher risk of stroke in the immediate year after. That risk dropped off, but it was still a little bit above women who were not taking HRT. So I think.
Do we know what age they were? Because there always seems to be this sort of window of opportunity. If you start, they say if you sort of start HRT before or within a year, within 10 years of menopause, really seem to be relatively okay. But then if you're beyond that window, if you're sort of in your 60s plus and starting, then there seems to be bigger risk.
Yeah, I mean, I think that's coming back to the first point, that comparing exactly like for like is quite tricky, because different groups started taking slightly different balanced medications in slightly different formulas at different times. But
They have changed
yeah,
significantly over the last.
yeah. So it is tricky, and I think I wouldn't. I think what I would say from reading the evidence, or certainly having a look at it, and is that if HRT conveys benefits in terms of your well-being or whatever that might be, then I would have no problem with any of my patients having HRT. Certainly as a primary prevention, people who haven't had a stroke. If I was a GP, I would counsel someone about the perhaps slightly increased risk of a stroke, but I wouldn't say don't take it. Whereas there's sometimes people come to me and they want a treatment that just isn't appropriate for them, and I would tell them that. So I think it's something up to an individual choice based on the patient's preferences and the patient's symptoms. I think, to be honest, that's how I would view that.
In many ways, if you started, if your symptoms of menopause are, I'm so tired, I can't get off the sofa and I'm eating junk food 24/7 and whatever, you're elevating your risk factors. Whereas if it gives you the energy to get out there and exercise and reduce them, then there may be some benefits.
And I wouldn't necessarily. I would look at it in the specific terms of the specific patient. So if it was exercise that a patient found they could do with HRT, fantastic. If it was hot flushes that were unbearable and that was an individual. Equally, if it was someone that said to me, well, things aren't that bad really, or they're getting better, then it might be, well, let's just see how it goes, So I think it would be very, it would be very tailored to what that patient was saying to you in front of you.
Yeah. Interesting, actually. Anita, who's saying over here, she started HRT in 2018 and had an ocular transient ischemia attack in the following year, and is now on a blood thinner. So actually, tell me a little bit more about these transient ischemic events. What
it's basically a stroke that goes away. It historically, and I think still in many textbooks, the sort of definition is a stroke. So you have neurological symptoms, so weakness in the hand, slurring of the speech, or drooping of the face, that clears up in 24 hours. Now, if you've got something that lasts 24 hours, there's going to be a bit of damage in the brain. You might not notice it because the brain might compensate. It might be quite small. So we're moving away from the sort of 24 hours thing more to a sort of tissue-based damage. So it's a neurological event that can last a short period. But we know that if you've got symptoms for 2 hours, you've probably got some damage there.
What sort of symptoms are you talking about?
Let's just say that your face is droopy and your speech slurs. Now, often they're caused by tiny little blood clots, or actually little build-ups of often things called platelets, which circulate in blood and help the blood thicken. And basically, they just dissolve, or the blood supply around it sort of increases a little bit to sort of compensate. And the importance of them isn't, obviously it's a medical thing, and obviously you need to take that seriously from a patient's point of view, but from a doctoring point of view, we know, and there are various ways you can sort of score it, that if you have one of these TIAs and you have certain other risk factors like diabetes, or it lasts for a long time, we know that your risk of having another TIA, or in fact having another TIA and in fact stroke in the next week, can be as high as 30%, depending on what symptoms you've got and so on. And we also know that some of those people, in fact, often quite a high proportion of the people that have quite a high risk factor, have a tightening in the blood supply in the neck. And it's actually little clots are building up here, shooting off, causing strokes further upstream. Now, we know, and there's very good evidence, that actually if you have got one of those tightenings and symptoms that match, so if you've got a tightening, sorry, I'm just looking at the screen here, you've got tightening on the right side of my neck, I would expect that would affect the blood supply on the right side of my brain. So it would affect my left hand, affect my left side. So the right side of your head, I think that's, sorry, I'm looking at this, so I'm getting my lefts and rights mixed up. But this side of your head affects this side of your body, and vice versa. Okay. So if you've got a tightening, symptoms that match, we know that taking that tightening out really prevents the risk of stroke downstream. So that is actually what we want to do. We want to perhaps thin the blood, perhaps treat other risk factors, but really we're looking for this tightening in the neck. Okay, so that's the
like, you mean as in of the carotid artery?
Yeah, it's the carotid artery, and essentially it's in the same as you having a blockage in your heart, in your heart. You've got build up of fat, etc. It's just the same in the neck, basically, but it can actually become a bit unstable. So actually, instead of having a sort of smooth surface, it's got a rough surface, and on that rough surface is where the little platelets build up because they're being activated, because it's not the normal sort of inside of the blood vessel, which they're kind of, basically they're seeing it as though you're bleeding, so it's trying to stop the bleeding, if that makes sense.
Yeah, that makes sense. Is it worth then for people who've got like a high risk, like I mean, let's take me for example, why not? Grandfather drops dead of stroke, uncle drops dead of stroke, father has a stroke but doesn't drop dead and then has multiple strokes afterwards. Is it worth it for people like, let's say, Anita, who's already had a TIA, or people like me to be having, when you hit a certain age, to be having a carotid artery ultrasound just as
No, not actually. Be quite certain about that. There's very little evidence that if it's not actually playing up, so it can actually be quite tight, but it doesn't. It looks smooth, but more importantly, if you just found it, so you haven't got symptoms, so it's not, it's active because it's like a volcano, because you're getting symptoms further upstream. So if it's not active, there's the evidence to suggest that you would take it out or put a stent in to open it up is very poor. There may be certain indications, and if I saw a young person,
looking at what that tightness was like, and then thinking it might be better, you've really got to get on top of your blood pressure. You've really got to get on top of your platelets.
Absolutely. So in fact, actually, that's a very good point, which is that your medical management is better than a surgical management in those sort of situations. We know that if you have a high cholesterol, we reduce your cholesterol in your bloodstream. It sucks cholesterol out of these plaques, makes them more stable, makes them a bit smaller. So just being, so that's a very good point. So just being specific, it would be unusual to do an operation that isn't causing symptoms, no matter how tight. I say I might ask a vascular surgeon for an opinion, and they may take a different view and occasionally do an operation if they think it's the right thing for the right person, but the evidence isn't there for that, and it's not something I would normally do.
Okay, interesting. Now, you mentioned cholesterol there, so let's start at that as one of the risk factors. Why does cholesterol matter, and how can people make sure that they've got that under control?
Well, it matters because it helps cause blockages in the blood supply. It helps damage blood vessels, and we know, and there's really good evidence, loads of very different studies looking at statins and cholesterol in different ways, that if you bring it down, you do better from a stroke point of view, from a heart attack point of view, just, generally cardiovascularly you improve. Stroke specifically, we know that if you bring it down, it stops you having strokes. And we also know if you bring it down, it stops you having another stroke if you've already had one. Now, up until quite recently, I actually didn't measure it very often because I didn't care. All right. And the reason I didn't care was because I don't care what it is. I want it to be lower. All right. So it's not, I didn't, obviously, I didn't care in the sense of, it's 5.5. I'm not going to treat it. I would treat it if it was 5.5. I'd treat it if it was 8.5. Now, if it was very low, so obviously I would check it occasionally. If the total cholesterol was less than 3.5, I would have a conversation about whether it was the right thing, or I wouldn't necessarily increase a statin if somebody wasn't on a massive dose. So that was sort of my practice up until I think about a month, 6 weeks ago. I've had an interest in lipids over the years, so it can get quite complicated with HDL, LDL, different types of cholesterol. So my sort of advice, because I could remember it, and hopefully my GP colleagues could understand it simply, quickly, and deliver it without sort of bombarding them with stuff, was a total cholesterol of 3.5. Okay, because if your total cholesterol is 3.5, your HDL, your low cholesterol, isn't going to be too high. Now, about 6 weeks ago, the Stroke Association have just revamped their guidance. And actually, there's a couple of studies that have come out to say that the low density should really be less than 2.5. Okay, so I am actually going to start measuring it a little bit more and actually be a bit more aggressive with the low density and try and have that under 2.5. Now, we've usually used a statin. I occasionally add another treatment called ezetimibe, which sort of stops the absorption a little bit. The new evidence would suggest that you're a bit more aggressive with that ezetimibe. So you maximize the statin that somebody's on, and then you add this other tablet called ezetimibe to get that level under 2.5. There are actually some new injections which have come out. They're not sort of universal yet. So there are a new class of treatments for cholesterol that actually, I mean, it would be prescribed by a specialist, but I would, it would be unusual for me to refer someone onto that sort of thing. But I think if someone had a persistently high cholesterol, having had a stroke, there are new treatments, and perhaps we're moving to be a bit more aggressive than we were, although we weren't particularly passive in the first place. But if you know what I mean.
Mm-hmm. The question I was going to ask just went straight in. Statins, that's what I was going to say.
Yeah.
Surprisingly, there still seems to be an awful lot of misinformation around about statins. Should people be worried about taking statins?
No. Okay. All medications can and do funny things. All medications can react badly with individuals. And on an individual patient basis, I very much have conversations about whether a statin is for you. And it's not uncommon for me to have people come to me and say, look, I can't take a statin. All right. So I'm not going to force it on people that it's making them feel ill. The most common one is muscle pain. It's very well described. You take a statin, you get muscle pain. You stop the statin, it goes away. You can occasionally get it if you've been on the statin for a while. And again, just let's have a conversation about the right statin for you. There are strengths of statins as well. And actually, I'm just trying to remember, because when I was learning about the guidelines for cholesterol, I think the atorvastatin, which are the stronger ones, tend to be a little bit more fat soluble. Forgive me if I've got that wrong. And they tend to be a bit more, you tend to get a few more side effects because they're stronger. There are one or two that have a slightly different chemical profile and are much better tolerated. They're not such good statins. They don't reduce the cholesterol quite so much, but it may be that actually atorvastatin is too strong for you. There are other ones like fludrastatin, simvastatin is the next one down. Pravastatin, I think it was pravastatin that they said was the sort of the gentlest, if you like. So again, have that conversation. Okay, you can't take a statin. What about ezetimibe on its own? And then if somebody still can't take that and they have a high cholesterol, they're the type of person I might refer on for an injection. Okay, so coming back to your thing, should people worry about it? No, because it's not a particularly hazardous drug, albeit that in the context of side effects that can occur, which are well known and go away.
Yeah. In terms of things people can do for themselves to lower cholesterol, what would you recommend?
Yeah. Well, common sense, really. I mean, you don't need me to sort of say, exercise reduces your blood pressure, reduces your cholesterol a little bit, healthy diet, that the usual cardiovascular type things, really. I'm not for 1 second suggesting they don't help, but if you lost or lucky enough to lose 10 kilograms after your stroke because you were worried about weight loss and wanted to try to reduce your cholesterol, I would imagine it would come down. Whether it came down to numbers that I was happy with as a doctor is a different conversation. And again, if somebody's sitting in front of me saying they don't want to take a statin, I'm not going to force them. It's a conversation.
Digging my memory back to many, many years ago, I remember when I was doing physiology, there was a relationship between smoking and cholesterol. That if you smoked, it didn't break down the fat, the lipids. It made it harder for you to lower your LDLs.
I say I wouldn't disagree with that. I mean, to be honest, it causes smoking causes so much harm to your arteries in other ways that I think what it does to your cholesterol is probably just another bang for your buck with smoking. So yeah, smoking is the biggest modifier, what we call modifiable risk factor, or risk factor you can do something about for kind of so many diseases, and stroke is one of those. And I'm a man that took a long time to give up smoking, so I know it's not easy. But I do say to my patients, look, you know, I can give you these tablets. That's fine. They help. I'm not saying they don't, but the biggest thing, that the bigger than any of these tablets, is you stopping smoking. So, and actually we do prescribe patches in hospital. We do have, hopefully, or certainly I hope myself and my team do, have an awareness that smoking isn't easy to stop, and we try and help people. But equally, you know, they've had a major life event, and often that is something that is, you know what, that's it, you know. And I think, to be honest, not all, but certainly a majority of my patients will stop smoking when they have a stroke, because, you know, that's the choice that they've made at that point.
Yeah, it is difficult. It took me 15 years to only give them up after 25 years of smoking.
Yeah, I know.
Oh, horror. The other modifiable risk factor, high blood pressure. Are we aggressive enough with that? Because I think the stroke association.
No, we're not. No, we're not. No, we're not. There's something called the rule of halves, and it's quite horrendous, actually. So half of people who have high blood pressure, and I need to get mine measured, don't know they've got high blood pressure. Okay. Half of those aren't on any treatment, and half of the ones that aren't at the target required. So basically, if you can look at that another way, which is 1 in 8 people with high blood pressure have it treated to the recommended guideline.
It's not great, is it?
No. And, you know, we'll talk about an irregular heartbeat a little bit later, which is a big specific risk factor for stroke. But high blood pressure is the biggest one out there that isn't treated in the population as a whole.
So ideally, where would you like to see people getting their high blood pressure to?
Well, okay, so what sort of target would I want? Again, I'm a little bit nuanced with that, because I'm a geriatrician, so I'm an older person's doctor by training. So I've given enough people antihypertensives to make them fall over because they feel dizzy when they stand up. So you've got to get a bit of a balance, particularly as people get older and they lose some of that ability to kind of regulate their blood pressure as they stand up. It's what we call postural hypotension. But if you've had a stroke, I would aim for a blood pressure of 140 top number maximum, and 80 bottom number maximum. So anything below there. Ideally, and again, in a younger person who could perhaps tolerate more aggressive blood pressure management, I would have that top number at 130. Okay. And there are plenty of guidelines at 130. You know, you can, you know, even 120, 70. I mean, that would be aggressive, but 140, 80 is a sort of relatively hard stop. And obviously the higher above that, you would want to be more aggressive is the wrong word. You'd want to be more active in making sure that had come down. So you might see somebody a bit sooner, or ask them to go to their GP a bit sooner, or what have you.
Yeah, because I mean, it fluctuates a lot, your blood pressure during the day, doesn't it?
Yeah.
And so should people be sort of monitoring it? Should everybody have a high blood pressure machine at home? Should they be monitoring themselves a couple of times a day and sort of getting a good average of where they're at?
I mean, yes and no. I mean, lots of my patients do have their own home blood pressure monitors. Obviously, that's very helpful because, you know, you eliminate white coat hypertension and people rushing up and all that sort of stuff. So, you know, you get a good idea of where their blood pressure is. So I'm very much in favor of them. I mean, they're not desperately expensive. If you were going to buy one, it might be worth buying one for 15, 18, 20 quid rather than sort of 5, 7 quid, just because you're going to get slightly more accurate readings. But really, you know, I often, you know, the practice nurse is usually you know, available to take a blood pressure if you haven't had one done for a while, if you're worried about it. And then if it is up, they can sort of escalate it to your GP, and you can go for a sort of conversation about what you want to do about it. So, you know, blood pressure, unless it's very high, is not something that needs to be dealt with at that point. It's a problem for years and decades. So it's a different conversation at different points in people's lives. And equally, as you get to the extremes of age, very elderly, you know, do you want extra tablets? to bring your blood pressure down by a tiny bit, so it's in guidance? Probably not, but you know what I mean. So it's again, it's individual patient.
Yeah, for midlifey type people who are thinking now, I want to reduce my risk for later on. What would you be aiming for then?
Well, again, I would say that really, I'd say 140, 80. That's a pretty good ballpark. So even if I was your GP, we could manage something between, I don't know, 140, 150, that's fine. But if you'd had a stroke, we would be saying actually it needs to be south of 140. It's just, again, it's those are reasonable figures. I wouldn't want it much above those. But equally, I wouldn't necessarily, so again, talking from personal choice, I wouldn't necessarily want to go onto a medication unless it was much above that, to be honest. Although, ideally running at sort of 130, 120, 70 would be, ideal.
Yeah, I think the dementia people are now saying they want to have it down around the 120 mark, the systolic.
Yeah, they do, but then all their patients are going to start falling over soon, so they'll revise those guidelines in about 5 years.
Yes, I mean, as you say, I suppose it depends on how old they are and how well they can tolerate.
Well, I think, how well you can tolerate the medications. I mean, I said I would not disagree with that. My 140 in my population, predominantly older people, is based on pragmatism necessary, rather than sort of aggressive kind of, I know I'm going to cause more problems by driving someone's blood pressure down to 120 than I am to have them tolerate one tablet, take one tablet and keep it at 138. If I say you're taking 3 tablets, they won't take any of them, or they'll get side effects, or they'll fall over, or the tablets will interact with something else. So, it's about pragmatism for me. It's about delivering a treatment that the patients can tolerate and will take.
Yeah. In terms of things that people can do themselves, apart from medication, to bring blood pressure down, what do you suggest?
Well, again, weight loss and exercise do have a definite effect on blood pressure. I think if you lost a significant amount of weight, if you sort of exercised, including aerobic exercise, 3 or 4 times a week as whatever's recommended, I think your blood pressure would tend to come down. It would tend, if you were very lucky, you might get a 5-point reduction in those numbers. A good reduction would be 3 points. So it's not going to bring someone's blood pressure who's got a consistent blood pressure of 160. It's not going to drop it to 140 in the vast majority of cases. So I think while those are very, very much would like those conversations with my patients and with patients have with their GP, I think again at that point that there's probably no point waiting 2 or 3 years to see if it makes a difference. You would probably want to be having a slightly different conversation with those people about, look, we're probably going to need a tablet before anyway. This is all good, but you're probably going to need a tablet before anyway. If someone's blood pressure was say 142, I would say, right, go away. Good luck. I'll see you in 6 months. Let's see how it's going. Yeah. So it's a sort of,
Yeah. Diet, salt.
Yeah. Salt in the diet does tend to raise the blood pressure a little bit. You need a bit of salt in the diet. So I'm not somebody that doesn't include salt in my diet. I mean, there is salt in so many things that you don't sort of realize. Bread historically contains a lot of salt. I think that's slightly better than it used to be. So you do tend to take salt into your diet anyway. I do add it to food. I do add it to, but it's not. I don't pour it on like my granddad used to do. Let's put it like that.
Yeah, I mean, there are certain. I mean, you cannot have mashed potato without salt in it. It's just.
I think chips. I think, to be honest, yeah.
Anything potato has to have salt for some unknown reason.
True.
Other risk factors. What else should people be thinking about?
What have we covered? So diabetes is probably the other big one. Again, that is very much weight driven. So particularly someone on the verge of developing diabetes, because it comes on over time, weight loss there really does have a very good impact in improving the sort of diabetic profile, if you like. So you're basically as you get typically, as you get older with type 2 diabetes, not the sort of diabetes you tend to get when you're younger, although you can get it when you're an adult, where your sort of pancreas can just completely fails and you have to give insulin. As you get older, it tends just to kind of wear out a bit, so it's not as good. And also, there's a bit more of us, so it's got a bit further to go round, and the fat itself doesn't let the insulin work as well as it would do without. So thinner people, the insulin tends to work better. It's a very simple, simplified generalization, but it's kind of how it is. It's something called insulin resistance, insulin sensitivity. The fat makes insulin not as effective, basically. So there's definite evidence that if you lose weight there, your diabetes will improve. So that would be that. If you haven't, if you have got diabetes, then we used to use something called HbA1c. We don't now. I think it's IFAC. It's a marker of how good your diabetes are. And I think the normal level is 70. Forgive me if that's wrong. I say I don't. I still work in old money, which is HbA1c. And we would look for an HbA1c in old money of about 7, basically. Anything above about 6 implies that you have diabetes, but if you've got a stroke, we would try and drive that down. Again, there'd have to be a certain amount of pragmatism there. You know, what's the patient on? What can the patient take? You know, if you've had a large stroke and you can't inject yourself with insulin, it's a question of getting your diabetes regime balanced, right for you, not necessarily driving your blood sugars down to reduce your HbA1c. So again, diabetes is very tailored to the individual. So diabetes, smoking we talked, blood pressure we talked, diet and exercise, cholesterol we talked about. What other risk factors? They're most of them. If we see a younger person with a stroke, anyone below about 60, I tend to do some fancy blood tests. I saw a paper about someone who'd done 750 of these different blood tests, and there's about 10 for each person. They'd done it on 750 different people, and they never found a positive result. And I was beginning to feel the same until about the last year. I've had 2 people actually come with these slightly unusual conditions that thin the blood. One of them actually had something called antiphospholipid syndrome, and that was interesting from a doctoring point of view because actually it's very common in women. I think it's something like 9 to 1. So the vast majority of people with antiphospholipid syndrome are women, and this was actually a chap. Now, again, I'm sort of digressing a little bit, but it's possible that we see it more in women because actually women who have trouble conceiving, they have a lot of miscarriages. So sometimes this will kind of flag up with sort of women who are going through trying to get pregnant. But so we saw it in a man. We're slightly more aggressive with how we thinned his blood, and then I saw it in another. I saw a slightly different syndrome in a man as well. But anyway, so I digressed again. But basically, there are.
The thing about that though is that if you were a woman who had that problem with conceiving and had multiple miscarriages, somebody should probably talk to her about, you might want to think about making sure you get all of your risk factors for stroke and heart attack.
And to be fair, I think we usually I think GPs do tend to have those conversations. I mean, again, I'm sort of generalizing, but so we certainly do try and be a little bit joined up about these sort of things. I think it would normally be a rheumatologist who would see someone with antiphospholipid syndrome, and I think they're the type of conversations they would sort of have with somebody.
You would hope that would be a good thing. Anita is asking here, and you mentioned before about different types of heart rhythms, and we often find that women, once they hit menopause, they tend to have a lot of thumping in the chest, waking up at night feeling like they've got a drum beat going in there, palpitations, tachycardia, those kinds of things. So what are they, and which are the ones that you would worry about in terms of stroke risk?
Okay, so that's a really good question. Now, can we just go back one step because it will lead into this? So the risk factors that we talked about there, we've kind of talked about the treatment. So it doesn't matter if it's what's called primary, so it's to prevent a stroke, we're perhaps not quite as aggressive, or secondary to stop you having another stroke. Okay, so you'd want to treat diabetes, cholesterol, blood pressure. Okay, now if you've had a stroke, or if you've got a certain type of heart rhythm, which I will come to, we thin the blood. All right, because we know there's very good evidence that if you thin the blood, you stop having another stroke if you've had one, or if you've got a particular type of heart rhythm, it stops you having a stroke. All right, so let's just to start with take people that have had a stroke. All right, okay, now if their heart is beating regularly, all right, and they've had a stroke, and an ECG will tell you if someone's heart's beating regularly. A lot of people have a slightly irregular heartbeat, which we'll talk about, and it's probably a bit more common than we've thought about because it's a risk factor for stroke, which we're coming on to. We quite often now do a heart tracing, usually for 24 or often 48 hours, just to see if they have an irregular heartbeat. Because if you have an irregular heartbeat, we treat it differently, okay, which is the second part. So assuming it's beating regularly, we thin your blood with aspirin for 2 weeks, and then we use something called clopidogrel, all right, which is an aspirin but works like an aspirin. It works on the platelets, but it doesn't irritate your stomach. It's a little bit historical why we do 2 weeks of aspirin and then clopidogrel. It's just the way the trial was done that showed that it was beneficial. Okay, so we tend to use aspirin for 2 weeks at 300 milligrams, and then we move to clopidogrel. If you're on clopidogrel and have a stroke already, then they put you on aspirin for 2 weeks and then they put you back to the clopidogrel. Okay, both aspirin and clopidogrel stop you having strokes in the future, but clopidogrel doesn't irritate your stomach. So aspirin thins your blood and irritates your stomach, so can cause bleeding, either bringing up some blood or some blood from the back passage. It is uncommon, but so many people are on aspirin, we see it quite a lot. Clopidogrel doesn't irritate your stomach. If you happen to have a stomach ulcer, you'll bleed more than you would if you weren't on it, but it doesn't cause it. So we tend to use clopidogrel. It's perhaps slightly better at preventing strokes, but it's definitely has a better side effect profile. So that's why we use clopidogrel. Now, just another slight digression, because people might have heard of this. In the press recently, the NHS have been talking about the fact that some people are resistant to clopidogrel. Okay, I think it's actually quite a high proportion. And they've got, you can inherit 2 genes. If you've got both of them, you're completely resistant. If you've got one of them, you're partially resistant. So the clopidogrel doesn't work so well. So at the moment, we're using clopidogrel, not testing where I am in Wales, but I think testing for clopidogrel resistance is something that might come. And again, if you're on clopidogrel because you've had a stroke, it might be something you want to have a conversation with your own doctor about, or if you're going back to a stroke doctor, talk to them about it. So that's the first thing. But if, say, you can't tolerate the clopidogrel, you just don't like it, if you're on aspirin, that's just fine. There's an old school one called dipyridamole that we used to use. Some people can't take aspirin, some people can't take clopidogrel, and they're on dipyridamole. That's okay. All right. We very rarely use 2 together. Okay. There was a trial out recently that if you've had a TIA or a very mild stroke, then actually aspirin and clopidogrel for 2 weeks together is what you want. And then you just go to clopidogrel. So sometimes we'll use aspirin and clopidogrel together, but it's unusual. Occasionally, people can have a problem with a heart, because they use these a lot in people who've had a heart attack, these type of drugs. And occasionally we'll see people on aspirin, dipyridamole, and there's another drug called I can never say it, something, sorry.
That's like too many letters, it just doesn't come.
Which is an antiplatelet that the cardiologists use, which you can use instead of clopidogrel, and that's as well. But so occasionally we'll see people on 2 for other reasons, but that's unusual. So normally it's 1 antiplatelet if your heart is beating regularly, right? Okay.
And in that regularly, are we talking about the occasional, little bit of tachycardia? Is that regarded as not?
So we'll come to the tachycardias, right? Okay, so there is a heart. So basically what your heart is 4 chambers, okay? The 2 in the right, get blood back from the veins, put it to your lungs, it gets oxygen in, goes back to the other side, and it gets pushed out. Okay. Now, on the top, there's two little chambers called the atrium, and basically they're just primers. They just sort of prime the big muscle underneath, okay, that does all the hard work, the ventricle. All right. But within the atrium is the electric circuit, basically, that controls it. So it's like a light switch. You turn it on and it turns your lights on. So the wiring starts in your atrium, okay, and it coordinates the little primer and then the big pump, right? So it makes your heart slightly more efficient. Now, as you get older and that gets bigger, and historically, rheumatic fever used to cause a damage to the mitral valve, which is at the bottom of the atria. Your atrium can get bigger. As it gets bigger, it doesn't work very efficiently. And instead of switching that light on every single pulse, it just stops. And then it just kind of literally fibrillates. It's called atrial fibrillation. And the bottom chamber doesn't get that sort of priming link. All right. Now, if you think about it, it's obvious. So you've got a little baggy sac at the top of the heart now, instead of something that was pushing blood through. Blood can sit in that little chamber, form blood clots, and then it gets straight out of goes into your big chamber in your heart and goes straight up to your head. So that is what causes big strokes often. All right. So we know that even if you haven't had a stroke, if you thin the blood historically we used to use warfarin, we now use something called a DOAC, okay, which are just a single tablet. You don't need a blood test. They're much more reliable because the levels in the blood are much more consistent than warfarin that used to go up and down. We know that the vast majority of people who have atrial fibrillation should be on one of these DOACs. All right. Now, there's a scoring system. Okay. And again, I'm being a little bit technical, but there's a reason for that, called oh my God, I use it every day. What's it called? Chad's VASC score. It's come back to me, which was developed by initially a guy in Leicester. There's really big studies on this. Now, the reason it's important, each of those numbers and letters counts for a risk factor. So like heart failure, previous stroke. But the important thing is you get 1 if you're over 65 and you get 1 if you're a woman, right? So any woman over 65 will score 2 by definition. You can't score less than that on that score. All right. That's even if you haven't got blood pressure or had a stroke or whatever, you can only score 2. And we know that the risk of having a problem by taking a blood thinner is the same as a woman and having a stroke per year who has a risk score of 2. All right. So any woman over 65 with atrial fibrillation should, as a general rule, be on a blood thinner. All right. Now, there is a balance score against that called the Orbit score, which looks at your risk factors for bleeding. It's not quite so well defined. There isn't quite so much data in it, but it gives you an idea. So if somebody has a high Orbit score, they've got risk of bleeding, then I wouldn't be so pushy about somebody having a score of 2 to go on a DOAC. It's more of a balance. So there is a sort of check against that for bleeding risk. All right. Now, so that is people who haven't had a stroke, all right, to prevent a stroke. And people that have had a stroke, again, would normally go on to that, unless they've had a bleed, because we wouldn't put them on a bleed, although that's another conversation, because there might be some benefit there counterintuitively, but that's for another day. But so you've had a stroke and you've got atrial fibrillation, we would want to thin your blood as well, all right, with an anticoagulant. And there's no evidence that an antiplatelet, so aspirin or clopidogrel, prevent clots in the heart. All right. We used to use them back in the day when I was a boy, but we haven't for like 10, 15 years because there just isn't the evidence they prevent them. The other thing is you can get something called paroxysmal atrial fibrillation. So it beats irregularly for a short time and then goes back to normal. And those people, that risk is the same as somebody who's in atrial fibrillation all the time. Okay. And they should be on a blood thinner as well. Now, to come back to your question about palpitations, if you can feel a palpitation, it's usually what we call an ectopic beat, all right, which is just your heart just having another beat, and it really doesn't worry me as a doctor. I know it worries patients. I know it's obviously symptomatic. It's worrying. I know that. But from a doctoring point of view, there's nothing that I need to do. Okay. So if I saw you, for example, Fiona, and you came to me saying, I'm feeling palpitations, we'd go through them. We'd find out what the story was. I'd check your pulse. You'd have an ECG outside. And if you're in sinus rhythm, so it's beating regularly, and it's very easy to tell on a heart tracing. There's just a little bump before it. It's one of the probably the first thing you learn when you start looking at them. It's very straightforward to see if it's normal. We'd say, okay, let's do one of these 24 hours or 48 hours, or if it's an outpatient, I'd often do a 7-day monitor to see if you do get funny heartbeats in the time. And in somebody, in a woman describing symptoms around the menopause, I would expect them to be ectopic beats. Okay. Now, if I saw bits of atrial fibrillation, we'd go back to that conversation. We do your risk factors about prevention for stroke. But normally I wouldn't expect them to be anything that I would worry about. Okay. Does that make sense?
Yep, that makes sense. And I think, again, dragging my memory back, you have around about 36,000 heartbeats in a day, and I think there's a sort of tolerance level, isn't there, around about 3,000 ectopic beats that you think if it's only 3,000 of them, we don't really care.
Yeah, and I mean, I think, to be honest, then it when I say there's nothing to be done, it is clearly going to be distressing for somebody who's having 3,000 ectopic beats a day. And again, I'm not a cardiologist. I would probably refer someone on to a cardiologist if they were that symptomatic with that many ectopic beats. I imagine that there are one or two tablets that would relax the heart, propranolol, beta blockers, that sort of thing. Again, I would refer someone onto a cardiologist, but my feeling would be that they would probably start something like that, like a sort of beta blocker, which just slows the heart down, just gives it a chance to beat a bit more regularly. But again, that would be a conversation for somebody who dealt with irregular heartbeats a bit more frequently. But
let me take you back to the clopidogrel, or as we call it in Australia, clopidogrel. Anita is asking, I'm assuming that if you had a transient ischemic event and you were put on something like this, that your GP would be regularly monitoring your bloods, and they would be able to tell whether or not it was working for you, wouldn't they? Because your platelets wouldn't be.
Sorry to interrupt, and just to come to your question, Anita, it basically it doesn't work at that level. So if you're on an aspirin, your platelet level will be just the same. They just don't work quite so well. So the sort of standard blood tests don't show that the clopidogrel isn't working. You might notice, I mean, men often tell me, they're on clopidogrel, they nick themselves shaving, I'm bleeding a lot more. So, I might not get that necessarily, but that's not a hard and fast sort of science. But as I say, there is a specific genetic test that you can do to see whether you have the gene that makes you resistant to clopidogrel. It's, I don't know, P49767344925. I can't remember, but it's well described. And I would just tick it on my form. As I say, it's not universal testing isn't here yet. It's not going to be long because people are asking for it. As I say, I imagine my colleagues in Wales will get a policy together fairly soon and probably start testing maybe in Cardiff to start with, and then certainly in the big centres to start with, Cardiff, Swansea, and I think it would be a per request basis at the moment, but I suspect in 5 years everybody who goes on it will have it actually.
All right, so something that she could request and
whether it's quite hit general practice yet, because this was quite recent news. I'd imagine your GP would be aware of it. Whether they are in a position to offer it locally via the NHS or not at the moment, I don't know, but it's certainly something to have a conversation with about.
All right. The other thing that is interesting about strokes and heart attacks with women is that once we've had them, apparently we do worse afterwards. Do we know why, and what can we do to recover better afterwards?
Yeah, I mean, I've done a little bit of work on this over the years. I'm an associate professor in Cardiff in sort of my other job doing research, and I've done some stuff in patient-reported outcome measures, and particularly the sort of mental health domain, which was one of the sort of areas of the particular instrument we used. And women did tend to have more depression, more anxiety, those sort of things, more fatigue after stroke. Stroke fatigue after stroke is very common. I've got a nice trick, but don't tell anybody, that when I have medical students with me, which I do most weeks, I will say to them, at least one person will tell you they're feeling tired when they work through that door in outpatients, and I've never been wrong yet. And I sometimes have to guide the conversation to make sure they answer the question. But the point is that about 50% of people that have a stroke are tired, and probably that's more likely to happen in women. Not massively. It's not that, 70% of women will get fatigue and 10% of men. It's probably, it's sort of 55-45, but it's there. As to why, not really. And whether there is, again, whether I think women perhaps more predisposed to depression and anxiety in men than in general. But again, that would be you're verging onto my psychiatry knowledge, which is pretty scant. So, but just to say that women do get certain things a bit more. Yeah.
Yeah.
But we do. I mean, I don't really work in those terms on a day-to-day basis. I'm not saying those differences don't exist. I think they do. They definitely do. But I don't think there's any one thing after a stroke that I would associate with a woman, and one thing after a stroke that I would associate with a man, if you know what I mean. Men don't have problems with incontinence more than women, or vice versa, or men don't have worse pressure sores after a stroke than women, for example, or what have you. So it's just, when you look at the big numbers, there's a bit of a difference, but stroke disease is fairly indiscriminate, unfortunately. Yeah.
True. So any take-home messages that you would like to share with people if they're worried about their stroke?
Probably blood pressure, actually. Just check your blood pressure, actually, because it's the biggest unknown. And then the other thing is just, I suppose, just take your pulse. I mean, a lot of smartwatches these days do will check your pulse to make sure it's regular. Or just, put your finger on your wrist. If it's regular, it's regular. It's not rocket science. There we go. Just if you can see. Just take your pulse. Yeah.
Yeah. It's a scary thing, though, when you think about it, especially for for many people, because if we think it's the third or fourth biggest killer of us, it's if you can prevent it, that would be a very good thing.
Yeah, it will. And also, again, it's also got a huge. We didn't talk about some of the newer treatments, the sort of clot busting treatments, and also what's called thrombectomy, where they fish out the clot. But the other thing about stroke disease, it has a huge burden in the widest sense of the individual, of the family, carers and support network, and of the sort of health economy, because stroke is a chronic disease. So, someone has a stroke at 55, they can't work for 5 years, but also potentially may have very high level care needs for 20, 25, 30 years. So you are left with a burden of disability, and disability just is a very big term encompassing a lot of different aspects, but it's something that doesn't go away. So it has a huge sort of implication further down the line.
Absolutely. M. McGrath over here is asking, okay, it's nice to say just take your pulse, but how do you know if it feels like it's regular or not? Are you long pauses?
Don't worry about a pause. It's fine. In the fact that just literally, can you bang it out? Doesn't matter how slow. And the odd, is probably the fact that you're going to be a little bit nervous about it. You get the odd ectopic, but if it's just irregular. So atrial fibrillation is described medically as an irregularly irregular. So it's not, it just bounces about, basically. Yeah. Or just go to your GP and get an ECG. That'll be, that's probably easy.
Yep, that's true. They're kind of annoying to sleep with, but
all right.
The 24-hour ones. Yeah, but so be it. Brilliant. All right. If people want to find you, where do they find you?
Well, I suppose Cardiff University, Hewitt J2 is my email at cardiff.ac.uk. That's probably the best one. And yeah, hopefully it's been useful, and hopefully it's, I'm more than happy to hear from anyone if they want to hear any more.
Brilliant. Thank you very much. I'll let you go and get on with your day, and hopefully I'll speak to you again soon.
All right. Take care. Thank you very much.
Take care. Bye.